So there are four important aspects in the management of gestational diabetes. The first is medical nutrition therapy. In medical nutrition therapy, the most important is that these pregnant females should get a balanced nutrition diet. That means there should be an adequate proportion of carbohydrate, fat and protein. In carbohydrate, we should try to have a more of complex carbohydrate, because complex carbohydrate, they are a good source of fiber, as well as they have a low glycemic index. Because of that, it helps to achieve a better fasting and postprandial glucose levels. Second, we should also focus on the quantity of carbohydrate. We should take small and frequent meals. Second important part of the medical nutrition therapy is fat intake. So, we should try to avoid the trans fat intake. We should limit the saturated fat intake, and we can take the mono and polyunsaturated fat. But we should not mistake to replace our carbohydrate part with the fat part, because if we take more than the recommended fat, then it will lead to a increased lipolysis, and this increased lipolysis will lead to increased fatty acids in blood, and it will lead to increased insulin resistance. The third is protein intake. All pregnant females should have adequate protein intake in their diet, that is about 1 milligram per kg per day. So this was a medical nutrition therapy for the management of gestational diabetes. The second part is exercise. So in these females, both aerobic as well as the resistance type of exercise are recommended, but these should be incorporated in their lifestyle only after discussing with your gynecologist. The third part is medication. So in medication, the insulin is the first line therapy. It is completely safe, and there are two types of insulin that we usually use in gestational diabetes. One is short acting insulin and one is long acting insulin. Depending upon the blood glucose levels, the doses of insulins are adjusted. In pregnant females, normally we do not use the oral hypoglycemic agents, because these medications are transferred through placenta to baby, and there is a risk of development of congenital abnormalities. Regarding metformin, metformin can be used, but it is not a first line therapy, and in those females where metformin had been used in the past for the management of PCOD or for induction of ovulation, these females can continue metformin during pregnancy safely. Third important part of management is monitoring. It is recommended that all pregnant females should monitor their blood glucose level by glucometer by doing the frequent glucose monitoring. Second way of monitoring is measurement of HbA1c or a glycated hemoglobin. As during pregnancy, the turnover of RBC is increased, so HbA1c level can be falsely low. So during pregnancy, we try to achieve a target of HbA1c 6 or 6.5%, but without any risk of hypoglycemia. If there is a high risk of hypoglycemia, then this target can be relaxed to 7% also. The third way of monitoring is continuous glucose monitoring, which can be done by CGM sensor. It has been found the monitoring by continuous glucose monitoring sensor helps to achieve a better glucose control. It decreases the risk of hypoglycemias as well as a macrosomic baby or a respiratory distress at the time of birth.